Our next speaker is going to be Dr. Stephen Markowitz. So without further ado, Dr. Markowitz.
Greetings, everybody, and I want to thank Linda and ADAO for inviting me back to speak about lung cancer. And I also want to thank the previous speaker, Laura, for sharing her story with us, and we wish you the best. Glad you're getting excellent care. And what I'm going to talk about is a way in which I think we can try to avoid future suffering. Okay, so yeah, I'm funded by the Department of Energy to conduct lung cancer screening, and I have been for the past 20 years. So there's a puzzle around lung cancer screening, and I want to share what the puzzle is, and I want to help understanding why we have this puzzle. So lung cancer is the most common cause of death, cancer death in the United States, no question. It is also, among the established types of cancer screening, the least popular or common occasion for screening. This year, there will be 130 deaths from lung cancer in the United States. And it's both among men and women. Lung cancer death is the most common cause of cancer death. 22% of men, 22% of women. It equals the next two most common causes of death in each gender. So for women, it's equivalent to breast cancer plus colon cancer deaths, and in men, prostate and colon cancer deaths. So a lot of death due to lung cancer. And yet, lung cancer has the least rate of screening. Breast cancer and colon cancer, we have very good screening rates, 70 to 80% at present over the last couple of years. Prostate cancer, actually, there's no longer really any recommended screening for prostate cancer. The U.S. Preventive Services Task Force reviewed this a number of years ago and very much restricted its recommendations for prostate cancer screening. Yet, lung cancer, which was approved by them 2013, so it's been 9 years now, lung cancer screening is by far and away the least most common type of screening at present. And we need to change this. Among people exposed to asbestos, asbestos causes far more deaths from lung cancer than from mesothelioma. Obviously, all deaths caused by asbestos are tragic and terrible, but if you look at the numbers, lung cancer far outweighs the number of mesothelioma deaths per year due to asbestos. So, we've been talking, ADAO has really been in the forefront, suing EPA to address legacy asbestos, and there's been tremendous progress on that. By the way, I'm at the local library doing this talk outside, so there may be a little bit of background noise, I apologize. But in any event, so a lot of focus on legacy asbestos. We also need to focus on what Arthur referred to before at the beginning as the legacy of asbestos. I'm talking about exposure, particularly heavy exposure that occurred in the 60s, 70s, into the 80s, and to a lesser extent, but persistent into the 90s, to the present. But if you think about the people heavily exposed in the 70s into the 80s, they're now of the age 60, 70, and 80, where they are at the highest risk for lung cancer. And I found this table, I think some will appreciate this. This is from a classic study by Bill Nicholson at Mount Sinai, 1982. This is Bill Nicholson and Dr. Selikoff predicting, actually, what's going to happen over the next several decades with asbestos-related disease. And they focused in on these traditional occupations, industries, at high risk, again, going back in time. And of course, the actual population at risk from asbestos is far broader than this. So in terms of the legacy of asbestos, what do we actually have to offer? What we have is an annual low-dose chest CT scan, which can detect lung cancer at an early stage. I mean, stage 1 or stage 2, and a person can avoid being diagnosed at stage 3 or stage 4. Here's the slide with a picture of a CT scan. This is from the middle of a chest, and it's just a slice from a CT scan, a low-dose scan, and it shows actually on the left, there's a mass in the left lung. Excuse me, it's the right lung, but it's on your left side, and it's surrounded by the black, which is the lung tissue, and you can see that isolated opacity or white area in the lung. And that's an early stage lung cancer picked up by low dose CT. That could be removed by Dr. Flores, Dr. Wolf, probably with a scope. And the person can actually then lead a normal life, be cured of lung cancer. It's a 30-second scan. It's simpler than colonoscopy, far simpler than colonoscopy. It's less uncomfortable than mammography. There are no injections, there's low dose radiation, and the person just has to remember to do it. It's now actually available at 4,300 different radiology facilities across the country. So it's widely available. Good news, also, more people are eligible for lung cancer screening than ever. The U.S. Preventive Services Task Force expanded their guidelines last year. I'll show you the next slide where I provide that detail. As I just mentioned, many radiology facilities offer this expert service, and low-dose CT is increasingly reimbursed by both private insurance and by government insurance. So last year, the arbiters of who should get screened expanded eligibility for low-dose CT, and they added what was amount to several million people who are now eligible for CT reimbursed by insurance. So these are the current guidelines: age 50 to age 80, so it's broader. Smoked at least 20 pack years. It was 30 pack years previously, so lighter smokers are now eligible if they quit 15 years or less ago. So those are the current reimbursable guidelines for lung cancer screening. You'll notice that, of course, the guidelines still don't address asbestos or any of the other occupational and environmental carcinogens, silica, radon, diesel exhaust, and the like. This is a major gap, a gap that really ultimately, unfortunately, is sort of on us to promote lung cancer screening among the populations that we care about. However, the major problem, piece of bad news is that almost nobody is taking advantage of lung cancer screening. Only 1 in 15 people who are eligible, according to those smoking and age guidelines I mentioned before, are even going for lung cancer screening. Why not? That's the enigma. They're not going, I think, because they're afraid of the lung cancer diagnosis. Some people aren't aware of this. Their primary care doctors aren't promoting it among them. Some people, it's a question of payment. That it would be out of pocket for them if they don't meet the guidelines. So there are a number of current obstacles, but we need to do something about this, the fact that we are not taking advantage of this hugely readily available opportunity to save lives. So our job really at this point is to educate and to motivate people. So what we need to do, the people who are on this call and this conference now, is to think of your family and friends who would be eligible for lung cancer screening age 50 and over, if they have a smoking history, even if they quit a long time ago, if they had a history of exposure to asbestos or worked in a job where they were exposed either to asbestos or any of the other lung carcinogens, if you have a family history of lung cancer, frankly, if you have a personal history of any type of cancer, and finally, if you have a history of chronic lung disease, those are the people who should be going for lung cancer screening. So think about your family and friends and tell them about annual low-dose CT. It's easy to do, it's readily available, and they should do it. And then beyond that, with the organizations, with the ways in which we contact the broader public, we need to get out there, educate, and motivate people to get screened. Thank you very much.
Thank you very much, Steve. One should add, I should add that Steve Markowitz, more than probably anybody else in this country, has been an advocate for this, for promoting low-dose CT lung cancer screening, has written articles that are published, and needs to be commended for this work. So thank you.